Hello guys, welcome to podcast 14 of Let's Revise MBBS, and today's topic is Antepartum Hemorrhage. So what is antepartum hemorrhage? As the name suggests, it is hemorrhage that occurs before birth. Okay, but it occurs after the fetus crosses the age of viability. So in India it is 28 weeks. So any bleeding occurring after viability but before birth is known as antepartum hemorrhage. Okay, in previous podcast we have covered hemorrhage in early pregnancy, where we saw abortion, ectopic pregnancy, MTP. So all these causes are for early hemorrhage. Okay, and today we are talking about antepartum hemorrhage. So causes for antepartum hemorrhage can be divided into three main categories. So first is placental cause, and placental cause we have two main causes, Abruptio Placenta and Placenta Previa. Okay, these are the main ones which we are going to focus on today. Second category is fetal causes. In fetal causes we have Vasa Previa, which we have already covered in previous podcast. And the next one is local causes. In local we have polyps, fibroids, etc. So let's start with Abruptio Placenta, which is the most common cause of antepartum hemorrhage. So Abruptio, AB. So you know abduction and adduction. Abduction is away from the body. Similarly here AB stands for away, and ruptio means separation. So abruptio means sudden separation of placenta from the uterus. So it's in the name itself. Now what can be the causes of abruptio placenta? The most common cause is hypertension. Okay, other causes can be trauma, right? Polyhydramnios, short umbilical cord, less than 30 centimeters, smoking. All these are the risk factors for abruptio placenta. Okay, you can relate. So if there is trauma, there will be separation. If there is polyhydramnios, the uterus will enlarge in size and the placenta can separate. Okay. Now, what are the clinical features of abruptio placenta? So here, obviously there will be bleeding, but this bleeding will be painful vaginal bleeding. Okay, and the color of the bleeding will be bright red. Right, and size of uterus will be slightly more than the period of gestation, because there is blood getting accumulated underneath the placenta. Right, and symptoms of abruptio placenta may develop suddenly without any warning. Okay, as opposed to Placenta Previa, which we will see later. So now there are three varieties of abruptio placenta. Three varieties are concealed variety, revealed variety, and mixed variety. So concealed is what? It's hidden. So whatever bleeding occurs is hidden in concealed type. So this type is most dangerous type. Why is it most dangerous? First of all, we don't know how much bleeding has been occurred, and second, the blood which has been accumulated there under the uterus, it can result into DIC. Okay, disseminated intravascular coagulation. So that's why concealed variety is most dangerous. Second variety is revealed variety. Revealed is any bleeding that is occurring comes out of the vagina and we can see it. We know how much bleeding is occurring and all that blood is coming out. So that is the least dangerous. And the third one is mixed type. So mixed is combination of concealed and revealed, and that's why mixed is the most common type. Okay, and now there is a term known as covular uterus. What is covular uterus? Whenever the bleeding is going on, that blood seeps into the myometrium and also sometimes till the serosa, and during C-section or during laparoscopy, the appearance of the uterus, this appearance of the uterus is known as covular uterus. Okay, you can see the image of covular uterus later. Now so complications can be DIC, which we already saw in concealed variety. Then the mother can go into shock because of so much bleeding, and fetal death can also occur. Okay, so for managing abruptio placenta, wait and watch is never an option, because it is a emergency, it is a serious condition. So what we need to do is resuscitate the mother and terminate the pregnancy. Okay, resuscitate the mother is give her fluids, correct the DIC which is occurring, right? And for termination of pregnancy, we can either go for vaginal delivery, instrumental delivery, or C-section. So if the fetus is dead, we go for vaginal delivery. Okay. If the fetus is alive, then we can either go for instrumental delivery or C-section. Most of the time we prefer instrumental delivery, but if there is fetal distress or if there is profuse bleeding which has occurred and which is affecting the vitals of the mother, we prefer C-section. Okay, this was about the management of abruptio placenta. Now I'll talk about page classification. Okay, this page classification is for abruptio placenta. We have 4 grades: 0, 1, 2 and 3. So 0 is, we come to know that abruptio placenta had occurred after the delivery. It is a retrograde diagnosis. When we remove the placenta, there is a bleeding. So this is grade 0 is retrograde diagnosis. Grade 1, in grade 1, 2 and 3. In all these 3 grades, bleeding is there. Okay. But in grade 1, fetus and mother both are normal. In grade 2, fetus is in distress, mother is normal. And in grade 3, fetus is dead and mother is in shock. Right. So these are the 4, 0, 1, 2, 3, 4 grades of page classification. Now let's move on to the next topic, that is placenta previa. Again, we'll understand its name. Pre. Okay, pre is before. Pre is before. And via is a route. I am going via this route. So via is a route. So fetus is going to come out via cervix. Right? So whenever the placenta is present just before the cervix or in the lower uterine segment, it is known as placenta previa. So now let's see about the classification of placenta previa. We have 4 categories or 4 grades: grade 1, 2, 3 and 4. So grade 1 is low lying placenta. Okay, we measure the distance from the internal os. So whenever the placenta is lying within 2 cm of the internal os, we call it low lying placenta, and that is grade 1. Okay, grade 2 is marginal. It just touches the margin of internal os. So here we have grade 2A and 2B. 2A is anterior. Okay, it is present at the margin, but it is anteriorly placed. And grade 2B is posterior. Okay. Now we have grade 3, where it covers the os, internal os, but it partially covers it. When the os is dilated, it covers the os. When the os is closed, it does not cover the os. Okay. And grade 4 is called as central variety, and it completely covers the os. Okay, so these are the 4 categories of placenta previa. So grade 1 and grade 2A are considered minor varieties, and grade 2B, grade 3 and grade 4 are considered as major variety. So for managing minor variety, we go for vaginal delivery, and for major variety, we go for C-section. Okay. Now let's talk about clinical features of placenta previa. So bleeding in placenta previa is painless, okay, as opposed to abruptio placenta. It is causeless. There we had a cause. We had hypertension or trauma. Okay, here there is no cause and the bleeding is fresh bleeding. So patient will basically complain that she was sleeping, and when she got up, she found herself surrounded in a pool of blood. So it's painless and it does not have a cause, right? So, and here in placenta previa, the uterus will correspond to the period of gestation. The height of the uterus will correspond to the period of gestation. Okay, and PV, per vaginal examination, is contraindicated in placenta previa. Okay, why is it contraindicated? Because when we do PV, it may rupture or it may disturb the placental attachment, and a lot of profuse bleeding can occur. Okay, that's why PV is contraindicated in placenta previa, but it is not contraindicated in abruptio placenta. So first we will do USG. We will identify whether it is placenta previa or abruptio placenta. If it is placenta previa, we will not do PV. If it is abruptio placenta, we will do PV. Why we will do PV? To rupture the membranes, or to artificially rupture the membranes, so that whatever blood has been accumulated inside, it will come out, and hence the chances of DIC will decrease. That's why we go for PV in abruptio, but PV is contraindicated in placenta previa. Okay. now after we have diagnosed that it is placenta previa, we do transvaginal sonography to grade it, whether it is grade 1, 2, 3 or 4. So for that we do transvaginal sonography. And now how do we manage this placenta previa? We have two ways. We can either do expectant management or we can manage it definitely, or we can do definitive management. Okay, definitive management is termination of pregnancy either through vaginal delivery or C-section. Here expectant management is important. The regime for expectant management is known as McAfee and Johnson regime. Okay, the aim of this regime is to allow the fetus to obtain the maturity, but not at the cost of mother. The mother should not be at risk. If that is the condition, then we can continue the pregnancy so that the fetus attains maturity. So when will we go for expectant management? When the mother is hemodynamically stable. Okay, if the gestational age is less than 36 weeks and there is no fetal distress. Okay, in those conditions we will go for this McAfee and Johnson regime. So what we do is we admit the patient. Okay, we arrange for blood because anytime a lot of bleeding can occur and we need to maintain the hemoglobin. So we arrange for blood. We also, if the mother is Rh negative, we also arrange for anti-D, and we give the patient injection of corticosteroids for the fetus, for lung maturity of the fetus. Okay, and if contractions start before 36 weeks, we can also give her tocolytics, right, because we want to prolong the pregnancy at least up to 37 weeks, right? And then once the fetus matures, then we go for definitive treatment. So if the placenta previa is of grade 1 or grade 2A, we go for vaginal delivery. If it is grade 2B, grade 3 or grade 4, we go for C-section. Okay, so that's about placenta previa. Okay, so we saw four main classifications, or four classifications you can say. First one was varieties of Abruptio placenta, then the Page classification, then the classification for the grades of placenta previa, and last one we saw McAfee and Johnson regime. Okay, so yeah, that's it for today's podcast. One sign I forgot to tell you, it is stall-worthy sign. Okay, so what is stall-worthy sign? It is seen in placenta previa, in posterior varieties of placenta previa. Whenever the fetus head is pushed into the pelvis, okay, its head compresses the placenta and the blood flow to the fetus is decreased and the fetus goes into distress. So this is known as stall-worthy sign, right? So that's it. Keep studying and enjoy.